Hi, Golf, are you there?
Yes, I'm here, Dr. Chong. So it's 1 minute to start. Okay, I will let you know. Okay.
Yeah, thank you.
Yeah,
Have you had your lunch?
I think Dr. if I'm not mistaken, normally the talk always like 5 minutes late. So wait for more
Daddy,
people.
welcome. Okay, you have 1 minute to speak.
Yeah, I think you can start maybe about 8:05 or 8:10 if okay.
No, it's okay.
It's always a culture, they always join late.
Okay, so everyone, we already have 147 participants waiting in the room. So welcome. Okay, Dr. Chong.
Recording in progress.
Go ahead, Dr. Chong.
Hi.
Okay, please start the session, Dr. Chong.
Hi, can you hear me?
Yes, we can hear you.
Yeah. Hi. Hi, Dr. Janine. Yeah. Thank you, Golf. I'm going to start the introducing our speaker tonight, right? First of all, I'd like to share with all the doctors from different countries. I'm Chong from Malaysia. I'm a general practitioner, and welcome everybody on board. Allow me a quick introduction to our expert speaker today. She's the Dr. Janine David, qualified as a GP in 2001. And she went on to become a GP trainer in the year 2005. And she has a particular interest in testosterone deficiency and testosterone therapy. Hence, it is not surprising that Dr. Janine David is the secretary of the Primary Care Testosterone Advisory Group in the United Kingdom, as well as she's a member of a few societies here. I can tell you that she's in the British Society of Sexual Medicine, the European Society of Sexual Medicine, as well as the International Society of Sexual Medicine. It's good to note that since 2013, she has become the fellow of the European Committee of Sexual Medicine, and is a prestigious award and one of the highest qualification for the field of sexual medicine. Apart from that, Dr. Janine David has also been involved in many research, and she has published widely and extensively in a field of interest, and she has co-authored as well a book on the Men's Health Guidelines for General Practitioner. Currently, she is practicing as a general practitioner with a specialist interest in men's health at the Porthcawl Medical Centre in Wales, and as well as she is the associate andrologist at the Princess of Wales Hospital. Also, she's a founder and medical director of Men's Health Wales. So it is our privilege to have her tonight, a very qualified expert in her field, to share her knowledge with us and her experience, as well as her practical tips that she's going to share with us. So without further ado, please welcome Dr. Janine David as our expert speaker tonight, and please enjoy her lecture. And Dr. David, the stage is yours there. Thank you.
Thank you. Thank you so much, Dr. Chong, for that lovely introduction. I'll share my screen now, so hopefully you will see it. There we go. There we are. So can you see that okay?
Yes, fine.
Yeah.
Brilliant. Okay. Thank you so much. I'm just going to minimize everybody, otherwise it's right on top of my slides. So thank you very much and welcome everyone. Thank you for the lovely introduction and thank you for joining us on a Saturday evening for you. It's midday here. Oh, Sawadee Ka to the Thai people out there, and that's it. I'm afraid I don't know anymore, but that's it. So yes, I'm going to be talking about testosterone, mainly really for GPs, and how we can screen and how we can prescribe it. These are my disclosures. So I had so many pictures that I could have chosen to show why women live longer than men, but this was just one of them. Recently, we've had this terrible storm over the last couple of days, and this is where I live in South Wales. So the picture on the left is the lighthouse in the summer. This is what it was like yesterday. And if you see in the middle there, there's all these guys taking photos when they were told to stay well away. So I don't know what we can do about men being naughty and taking risks. It's just life. We can only help them so much. And it actually made the Sydney News, Puthcall, my little town, because the weather was so bad with Storm Eunice. So I think in general practice, we're in a great position to help men because we're really good at preventative healthcare and we're really good at managing chronic diseases. And all this is about sort of preventing men developing these chronic diseases when they do come and see us. But the trouble is, men don't really come to the general practitioner as much as women. So you can see the women are in the red and they come throughout their lifespan. Often it's because they're coming with the children or for pregnancy issues and this sort of thing. But men only come at the extremes of life. So probably brought in as children by their parents, by their mums, or they come at the extremes of life, the older age. And the trouble with that is we're not then able to catch them when they come to help them with prevention. Why don't men go to the doctor? Well, rather do anything else but. And this new Cleveland Clinic survey found that only half of 1,174 adult men surveyed said that they get regular checkups. And 70% would rather do any household chores, such as vacuuming, than go and see their doctor. And when you look at testosterone deficiency, I did this online survey a couple of years ago to see why men didn't come and see their doctor and how long they'd waited. And of the respondents, a lot of them had waited up to 2 years before seeking advice. And why didn't they come? Well, they just thought it's not serious. They just think it's part of life, part of age, or they're just embarrassed. And they just thought these things would go away. And often when they are sent to the doctors, it's by their partners. The trouble with men. Are you okay? Can you all hear me?
Yes, Dr. Jenny, but please repeat this slide again because it's mute at the beginning of this slide. Sorry.
Just this one here?
Yeah,
no
just
problem.
This one.
Yes, just this one.
Great.
Just this one.
No problem. It's a technology, isn't it? So the term health literacy has been coined, and women have much better health literacy than men. And the trouble with men is that, as I said, they don't come to the doctor, so they're not exposed to healthcare services. They don't even go and visit pharmacies as much as women do. I mean, women do tend to go to pharmacies because they're a shop as well, and there's other items there. But because of this, they're not exposed to health. And men still feel, and it sounds sort of almost sexist, but men do still feel that being unhealthy is not very macho, and they still have this, which sounds a bit old-fashioned, but they still have this image of being unwell as not being manly, so they're less likely to seek help. And this goes part of the way to show why there is this discrepancy in life expectancy between the sexes. A lot of the diseases that men die from are these chronic diseases such as heart disease, stroke, diabetes and cancer. And a lot of these are associated with preventable lifestyle factors. And this guy on the right, the doctor's saying, the best thing you can do is give up smoking, drinking and fried food. And the guy is saying, well, what's the second best? Because men don't really want to do that. They just want a quick fix. And then, you know, obesity is a major problem, and especially with testosterone deficiency, the triad of obesity, type 2 diabetes and testosterone deficiency is well known. And I thought, well, is it because in the UK, you know, we've got this awful Western diet, and if you looked at a map of obesity in Europe, definitely the UK would be at the top of the list. So I just thought I'd have a look and see what the problem's like in Southeast Asia. And actually, sorry, Malaysians, you are up there with what would be the UK, you know, you've got quite a big problem now with obesity. And actually, you can see other countries there are not that far behind. And I think it's because you've got more fast food and things like that, unfortunately, coming into the countries. And so your obesity problem is on the rise, and this is an issue.
Okay, so moving on now from just general men's health to look at testosterone. And we're going to do a quick run through about testosterone physiology. Testosterone, as you know, is the major androgen in men. 95% of it is synthesized by the Leydig cells in the testes and 5% from the adrenal glands. And of course, it's necessary for fetal differentiation, to tip men into puberty, and to maintain the secondary male sexual characteristics. So the testosterone journey starts in the hypothalamus. The hypothalamus secretes gonadotrophin-releasing hormone, which tells the anterior pituitary to produce FSH, follicle-stimulating hormone, or LH, luteinizing hormone. And the FSH tells the Sertoli cells in the testes to produce sperm, and the LH tells the Leydig cells in the testes to produce testosterone. The testosterone then is on a negative feedback loop to the hypothalamic pituitary axis, just like lots of endocrine systems in the body, so just like the thyroid system. And testosterone story doesn't end there. Testosterone gets broken down in the peripheries to DHT by 5-alpha reductase and aromatase to estradiol, which happens in the fat tissue. So this is the trouble with obesity, because the more fat men have, the more testosterone is broken down. What is the role of testosterone in men's health? Well, it certainly affects mood and cognitive ability. We'll go on to talk more about symptoms and signs in a minute. It affects muscle mass and strength, and we know about that, don't we? We know that from sort of people who abuse it, that it's important for muscle mass and strength. Of course, we know it affects sexual function, so people have lower libido, and it affects erectile function. It affects how fat is distributed, so men tend to get the fat around the abdomen when their testosterone is lower. It's important for red cell production, so men sometimes present with anemia. It's very important for bone mass, so men can present with osteoporosis, and we'll go through this again. What exactly is a deficiency of testosterone? Well, it is a well-established and significant medical condition. It's characterized by deficiency of androgen levels with symptoms and signs, and it can be associated with advance in age and comorbidities, which we will discuss. It's not to say that all men, as they get older, will have testosterone deficiency. Indeed, testosterone levels will drop. But on the whole, the Leydig cell function in the testes is adequate to maintain adequate levels of testosterone, so men don't have symptoms. So it's quite different from women who will have that drop of hormones and that's it, that's the end of their hormones at menopause. But with men, there's a gradual decline, which is okay for most, but for some men, they do get symptoms and signs. So this is why it does happen with advancing age. And it can affect adversely many organ systems throughout the body and reduce quality of life and, of course, reduce sexual functioning. Let's look at the symptoms in perhaps a bit more detail. Psychological, changes of mood. So often men present with this, not so much a depression, but a feeling of flatness. So they often say they've lost their oomph for life and they just can't be bothered to do anything. So they'll go to work, come home and just sit in the house, don't exercise anymore, don't want to go out, they don't want to do anything. They're irritable with their partners or the children, and they just don't feel themselves. Often they have the diminished cognitive function, so they're not concentrating as well in work and not performing as well in work. Sometimes I've had men say to me, oh, they can't concentrate driving as well. So, and it is known to affect spatial performance. Physically, they may look a bit different. They may have decreased body hair, gynecomastia, loss of muscle mass, the increased abdominal girth, sleep dysfunction. I often have patients who say to me, all of a sudden they can't sleep anymore and they get hot flushes at night. Osteoporosis is important. Men often present with fractures and it's osteoporotic based, and this can be because of a testosterone deficiency. Cardiometabolic symptoms. So we'll have the changing in the BMI, as I've said, and the visceral obesity, metabolic syndrome, and 50% of men with type 2 diabetes will have a low testosterone level. And then, of course, there's the sexual symptoms that are perhaps a bit more familiar to us. So a delayed puberty, smaller testes, infertility. But when you're thinking about the older gentleman, a decrease in sexual desire, erectile problems, ejaculatory problems, and absence of early morning erections, which is obviously an important sign. How common is it? Well, this is difficult really to say, because estimates vary depending on what criteria is used to define testosterone deficiency. So what levels are used to say a testosterone level is low. And as I said, it certainly does occur with advancing age. But all these factors have different prevalences of testosterone deficiency. So obese men, nearly 50% of them will have low levels of testosterone if their BMI is over 30. We also I find waist circumference more important than a BMI. So a waist circumference above 102, but I think in Southeast Asia, that's even less. So it's more like 98 centimeters. Type 2 diabetes, 50% of men, as I said, with type 2 diabetes will have a low testosterone. Chronic opioid use, up to 75% of patients, men on long-term opiates, will have low testosterone levels. And that includes things like codeine-based opiates, so codigemols, cocodamols, all this sort of thing, which a lot of people are on, and it's becoming more problematic as we have more patients who are living longer with chronic pain. Fractures, as I mentioned, osteoporosis. And I think osteoporosis has always been thought of perhaps as more of a woman's disease post-menopause, and we don't often check testosterone levels in these people. And HIV, because it's associated with chronic disease. It's important to look at classification, so we can try and work out the cause of the testosterone deficiency. So it can be classified into primary. This is where you have testicular damage, so you'll have a low testosterone level, but you'll have higher gonadotrophin levels as the hypothalamic pituitary axis is trying to tell the testes to produce testosterone. Then you have secondary causes, so you'll have some damage in the hypothalamic pituitary area, so you'll have low gonadotrophin, so low FSH and LH along with low testosterone. And then you have this middle section, which is this functional testosterone deficiency. And this is the one that's more likely caused by the comorbidities and aging. What are the causes? So primary causes. This will be a problem, as I said, in the testes. So things that damage the testes, such as mumps, which you may have as a child, testicular cancer. This is an important one because these guys often present to oncologists. The oncologist will manage them for a couple of years and then discharge them. But obviously most men with testicular cancer will have had an orchidectomy, so they'll have 50% of their testicular production reduced. And these guys then go out and 2 years later, they're not really followed up, and it will come back to us in general practice really to be aware of this and make sure we're asking these guys about symptoms of testosterone deficiency or perhaps checking levels in these guys. Klinefelter syndrome is a talk for another day, but it's the most common genetic cause in men, and men often present actually in their mid-20s with infertility, and it turns out they've actually got Klinefelter syndrome, and it often gets missed. The secondary causes will be, of course, pituitary tumours, which is important to be aware of, Kalman syndrome, which is another genetic disease which always used to come up in our medical exams, so I've not actually seen one of them, and head injuries. Now this is important, especially when you're taking a history. I now always ask, have they done sports which are likely to cause head injury? And I'm based in Wales, so that's mainly rugby, but any sport that can cause, you know, a concussion or problems like that, because often the pituitary can get severely damaged with head injury, and men present later with a testosterone deficiency. It's crazy, isn't it, that the pituitary is the size of a small pea, but it has such an important role. And then the functional causes, drugs, obesity, diabetes, and increase in age that we will talk about further. Opioids, as I mentioned, can reduce testosterone levels by up to 70%. Glucocorticoids, of course, suppress the hypothalamic pituitary axis, and anticonvulsants because they increase SHBG, which I will talk about, which will lead to a lower availability of free testosterone, and antipsychotics. How do we diagnose testosterone deficiency? Well, I don't think this guy's meal is really that small salad he's got. Maybe that's just his starter. So it's a bit of a challenge, this, because as I've said, men don't come to the doctor, so treatment seeking is delayed, so they may not come for several years. when they do come, the signs can be a bit non-specific, a bit like thyroid, if you like. So they might present with feeling a bit tired, just not feeling great. And you think, well, it could be anything really. We don't really have great teaching on sexual health. I think this goes back really to an undergraduate level. I've got a couple of new trainees at the moment, and they've had no teaching. Things haven't really changed in sort of the 20 years that I've been doing training. There still isn't really great teaching on sexual health or how to even take a sexual history. Then there's this big problem with laboratory reference ranges, and I'll talk to you more about that in a minute. I've written no NICE guidelines. Now that is specific to the UK, but I'm sure this is a problem wherever you are, that there are no specific gold standard guidelines for general practice on testosterone deficiency. If there are, I'd love to hear about it, because this is a problem for us in general practice here, that we haven't got official guidelines to follow on that, or actually erectile dysfunction. And we don't have any financial incentives for men's health compared to women's health. So that's a problem, because not that GPs are money grabbing, but it does help us to help men if we are being paid for it. To remind us that clinical features of testosterone deficiency can actually start at higher levels than what are classified as abnormal. So loss of sex drive can begin when levels start to dip below 50 nanomoles per litre. But to diagnose testosterone deficiency, we need to have symptoms, signs, and ideally 2 low serum total testosterone levels or free testosterone levels, which we'll talk about. So what are the symptoms and signs? Well, we've talked a little bit about them, and I mentioned that men aren't, us as general practitioners aren't that great at taking sexual histories. So I do find these questionnaires quite useful. Men like them because men are different communicators to women, and they respond quite well to filling in forms and having numerical values for things. So this is called the Adam Questionnaire. It's quite quick to do, and it gives you an idea of if the patient may have a testosterone deficiency. So if they answer positively to question 1, do you have a decreased libido? Or 7, are your erections less strong? Or to 3 or more of the other questions, and that's classified as a positive Adam questionnaire. And I think this is quite easy to give out, and we'll talk about screening later, but you could just give this in your diabetic clinics or have it around the waiting room for men to fill in. Another questionnaire I use is the Age in Male Symptom Scale. This is longer and it is a bit more onerous, so I tend to give this to guys to take away with them. But the useful thing about this is that it gives a quantitative score at the start before they get treated. And men like this because as I monitor them, I can repeat this and they can see an improvement in an actual score. And they do find this, again, easier to fill in. And actually, men are very good at bringing this back into me in surgery. So it's another tool that you may wish to use. We need to do a physical examination. So we look for signs of decreased secondary sexual characteristics, as you know, decreased body hair, decreased testicular size, gynecomastia, the BMI, as I mentioned, but more importantly, measuring the waist circumference. I think that's far more important than measuring BMIs, because that is where all the fat gets distributed. And it's important to measure bellies, not go on trouser size, because obviously bellies go over the trousers. This guy here looks particularly daft, doesn't he? Because he seems to have got sunburnt as well as have a too big belly. How do we measure testosterone? Well, testosterone has a circadian rhythm, so it's important to measure it in the morning. So I say to them, please come and have your bloods done between round about 8 and 10 in the morning, ideally. If you've got shift workers, we say within 2 hours of waking up, if possible. As men get older, the circadian rhythm becomes less pronounced, so it's less vital. And if there's a choice of measuring or not measuring, it's better to just get the measuring done, but ideally in the morning. I talked a little bit about this free testosterone. Now, testosterone is bound to 2 things, albumin and SHBG. Only 2% of testosterone is free for the body to use. So anything that increases your SHBG will decrease your free testosterone level, and vice versa. And this is why it's important on the second total testosterone reading to also ask for an SHBG if your labs don't give you free testosterone readings, because it's more accurate to measure patients' free testosterone levels. A really easy way of doing this, and we have this thing called a free testosterone calculator app, and you can put the values in there. Albumin is pre-populated at 43 because it doesn't actually affect things that much, not much alters the albumin. You can just type in your SHBG and your testosterone, and then it will work out your free testosterone for you. And if you can't remember cutoff levels, it's all written on there as well. And as I said, we need to do it in the morning. It ought to be a fasting sample. And the reason for this is debatable, but fasting levels can alter by a significant amount. So we do at the moment suggest you have fasting levels. Whether this will change in the future, as it is a bit debatable, but at the moment we're saying, yes, please, morning sample, fasting. And we do 2 testosterone levels. I usually leave it around about 2 weeks in between because concomitant illness can affect levels, a bit like with thyroid as well. So you need to have a couple of readings. I measure luteinizing hormone and FSH because we want to work out the cause for the testosterone deficiency. So initially I would usually check a total testosterone level, 2 weeks later, total testosterone and SHBG to work out my free testosterone, gonadotrophin levels, and usually a prolactin as well. Levels, right, so this is important. This is the British Society for Sexual Medicine's action levels. Now, I think this is a global phenomenon that testosterone levels that come back from the labs vary wildly. Now, in Wales, for example, my cutoff for low testosterone is 6.7 nanomoles per litre. So it's really important that we remember action levels rather than the actual laboratory level result that comes back to us. So if a testosterone level is below 8 nanomoles per litre, then that is classed as testosterone deficiency and usually requires replacement therapy. If levels come back between 8 and 12 nanomoles per litre, this is borderline testosterone deficiency, and usually patients require at least a trial of treatment for 6 months. And over 12, treatment isn't usually necessary. However, that's obviously looking at total testosterone levels. And as I said, it's important that we get the free testosterone level as well. And the cutoff for the free testosterone level would be under 0.225 nanomoles per litre. And if you can't remember that, don't panic. It's all on the British Society for Sexual Medicine website, where there's a very easy guide to for general practitioners to look at testosterone deficiency. And also it's on the testosterone calculator app. So I just want to talk about this current situation because this, an example of a current situation, because this is related to testosterone levels from the lab. So, for example, let's say we have a 51-year-old gentleman who has seen a disease awareness campaign. So he's actually gone to the doctor with his symptoms. He had erectile dysfunction, lethargy, low mood, and a low libido. But his GP is not an expert, but he thinks, okay, maybe this could be testosterone deficiency. The GP orders a total testosterone level from the lab to get the diagnosis, and the laboratory test comes back with a level of 5.8 nanomoles per litre. So as I've just showed you, know, okay, that's below 8, so that's a low testosterone level. However, local reference range for the laboratory result is between 5 and 31 nanomoles per litre. So this result will just get filed as normal. Unfortunately, despite this guy having low testosterone and the GP knowing about it and checking levels, the guy will just get sent home with lifestyle changes, maybe prescribed a PDE5 inhibitor for his erectile dysfunction, perhaps an antidepressant for his mood, which will make his sexual function worse, and his symptoms don't improve. So this is why I can't stress enough the importance of knowing about action levels rather than whatever your individual laboratory levels come back as. Why is it so important to know about testosterone deficiency? And mainly because men with testosterone deficiency will have an increased mortality, so they're more likely to die, especially men with type 2 diabetes. So this was from a study in the UK, and really of the men that followed the men up for 5.8 years, and found that the type 2 diabetics who were hypogonadal and untreated had twice the chance of dying over that time compared to the eugonadal or the hypogonadal men who were treated with testosterone. So it's not just about symptoms, signs and everything. Mortality is quite a significant issue, obviously, and this is why it's really important to pick these guys up and treat them. How do we manage testosterone deficiency? Well, we need to confirm the diagnosis, so that's with our symptoms, signs, and our 2 blood counts. We do the physical examination. We've considered the etiology, so we've checked to see whether it's primary or secondary with our LH-FSH levels. We look for reversible causes, so we check they're not on opioids. If we can get them off, of course, we try and reduce them. We think about contraindications and cautions, which are few and far between, but active prostate cancer, an abnormal rectal examination or breast cancer would be a contraindication. Fertility requirement is important because if you treat men with testosterone, you will switch off their endogenous production, you will affect their gonadotrophins, you will reduce their FSH, which if you remember goes to produce sperm, and therefore we can render these guys infertile when we're treating them with testosterone. So it's important to ask about fertility requirement at all ages. And I've been caught with this before when I've judged someone in their 80s that they may not want to continue with a family, but they do. So I now ask everyone. And hematocrit. It's important that the hematocrit is under 54% before we start therapy, because treating with testosterone can increase your hematocrit count. So there are lots of different therapies available, but I think with you guys and us here in the UK, it's mainly gels or injections. And which method used is usually a discussion with the patient. Compliance is very important. And I discuss all options, including not treating. And of course, lifestyle advice is paramount to all these patients. The major goal of treatment is to maintain normal physiological testosterone levels and to relieve the symptoms and signs. And we want to be aiming for mid-normal range of levels, so usually between 15 to 30 nanomoles per litre. It's important to try and treat to around about 15 because that's where symptoms start to improve and that's where levels feel better. So I try to get them at least to sort of a level of about 15. 20 is probably optimal. And just a point about the gels that a couple of studies have noted recently. The 2020 European Academy of Andrology said the preferred preparation in the initiation of testosterone therapy would be a gel. And the 2021 update from the European Association of Urological Guidelines said that using gels rather than long-acting depot administration when starting treatment initially. What are the advantages of gel? Well, of course, they're fast onset. You get a steady state and it's usually achieved within 48 hours of application. And because you're putting something on every day, you get a uniform serum level. And we know that that's a fairly consistent bioavailability, and it's easy to titrate doses up so you can have an extra little bit. You know, it's quite easy to do for them. And you do get a rapid decrease if you stop treatment, if there's any sort of adverse effect. Disadvantages are, okay, you've got to put it on every day. However, I just think in women, HRT, which has been around for so long and very tried and tested, the best way of putting on HRT is via a gel of a daily application. So it is a good way of receiving hormones. Some men are lazy and don't want to put something on every day, but I say to them, well, you know, you're going to clean your teeth hopefully every day. You can just put it on, clean your teeth, and then get dressed back up. And it's as easy as that. The transfer risk we have to talk about because it's there. However, in the last 10 years, I have never seen anyone's wife or baby ever grow a beard, because I think for them to actually have a transfer risk, you really would have to rub your arm that you've applied the gel on in their face. You know, it just doesn't happen, but it is in the literature. Skin irritation at the application site sometimes does happen, okay, and then you may have to change them over to a different preparation. Just to show you it does actually work, and this was a study that looked at how levels increase after 90 days, and you can see After 90 days of treatment, the darker blue is 50 milligrams of, this was actually Testosterone, as it must have been done in, I suppose, the States. But levels went up to nearly 20, and then after 90 days with 100 milligram patch up to 27. So we know that good levels are achieved with the gels when they're absorbed. We look at intramuscular injections. So it is available to you and to us in the UK. Libido is long acting. So an advantage of it is that, yes, you're only having this 4 or 5 times a year. So theoretically, this avoids peaks and troughs compared to short acting injections. But I'll show you a graph to discuss that shortly. It's good because as the healthcare professional still has control over dosing. A lot of the studies involving testosterone have been around using Libido, and it has good efficacy because you know the product is going into the patient. But you can't stop it quickly. So if they've got any side effects or they don't want it anymore, it's in the system. It's quite painful at the injection site because it's a 4 ml injection. It has to be warmed. You need a nurse to give it. It has to be given slowly. So if they're not very good at giving it, it can be quite painful for the men. And obviously they can't self-administer it. There is an increased risk of raised hematocrit compared to gels. So sometimes I do have to change people off Libido back to gels or onto gels if they started on Libido because of this. And it's not really recommended, as I've said, from those couple of studies I showed you, but also from the Society of Endocrinology in the UK, that it's not recommended first line because of the risk of adverse events. There is also this problem of a microembolism, and this happens in about 1 in 100 patients. And I do see this in surgery. They're okay, but they do have to sit for a good half an hour after they've had the injection, and they can have quite a significant cough. Oddly, although this is just anecdotal, I have seen more of this since COVID. So whether people's lungs are a bit more sensitized, perhaps. This is just to show you how the Libido injection decreases over time. And as you can see, Libido's in the blue. By around about week sort of 6 to 8, it is starting to drop to too low levels, really. The red is actually a short-acting injection that I don't think you have, but as you can see, that gives you quite highs and lows, whereas at least the Libido gives you the steady decline. But I do find that with some men towards 6 to 8 weeks, they start having symptoms again, and I either have to reduce injection frequency, or I do sometimes top up with a gel for those guys as well. Do you switch or continue when you start patients on androgel? Well, how do I do this? Well, usually at the start, I give them the option. I say, look, there's gels or injections. I go through the pros and cons of both. Usually when I say to men, there's a gel or an injection, they are, oh, I don't want a needle, I'll have a gel. But it's patient choice. You know, sometimes I have patients who work away and don't want to travel with gels, things like that. Then once they've started on them, provided there's no local side effects and symptoms are improving, then I don't really see there's any need to change them. So I usually review them in 3 months. And if their levels have improved and they've improved symptomatically with the gels, I'm more than happy for them to continue. I don't really see any point in switching them over to an injection at that point, because it would be more work for us. They're happy on that. Why give an injection if they're happy on the gels? The reason perhaps that I would is if they weren't better, if their levels hadn't improved, or if they had a rash and they wanted to change. But on the whole, once patients are on the gels, they stay on them. What's the benefits of testosterone therapy? Well, better sexual function, better body composition, so less visceral obesity and better muscle mass, better mood, as I mentioned, reduce mortality risk, better risk of having anemia. So often you have these patients with this chronic anemia, so that can be improved, better bone mineral density, so less chance of fractures, and improved glycemic control. I just wanted to point out key trials, only very briefly, because this was a very big trial looking, and it was randomized, placebo-controlled, double-blind, looking at older men, so men over 65 with testosterone below 9.5 nanomoles per litre. And they were divided into androgel or placebo and monitored for a year. And all these parameters in the blue boxes were monitored. And then a year later, they found that the guys in the androgel group had better sexual function, improved physical function. So they looked at things like walking distance and balance. They had better mood and energy, less depression, reduced anemia, increased bone density, all compared to placebo. And also what was beneficial was that they didn't find any increase in prostate cancer or cardiovascular risk. And this is important to tell you about for when you're starting patients on testosterone therapy. It's really important that patients are good with compliance. So we must educate them at the start to say, look, you're not going to feel better overnight. It's going to take, well, I usually say at least 3 months to feel better. If they have symptom improvement earlier, then great. Because you can see, if you look at erectile function in orange, yes, okay, symptoms may start to improve within 3 weeks, but it may take up to a year to see the full improvement in erectile function. So the men have to be patient. Same with thyroid, isn't it? When we give patients thyroxine, I usually say, look, you're not going to feel better for at least 3 months, because it takes a while for the endocrine system to stabilize out. And similarly with the metabolic improvements, again, these can take even longer. So bone mineral density at the bottom can take a couple of years even to show improvements. So they're in it for the long term, and it's really important that we tell them this at the start so that compliance is maximal. And so how long do we treat patients for? Well, testosterone deficiency is a chronic disease, a bit like diabetes and hypothyroidism. So it's important that they realize this at the start, and we tell them this. I mean, even though I do this all the time, I still have patients who come back to me and say, oh, I just stopped taking it. And I think, well, I know I will have told you to carry on taking it, but they just stop anyway, because, you know, people forget, don't they? So with all the will in the world, you can tell them it, but they still stop. This is why it's important that we do monitor them and we do check our prescriptions that patients are taking it. It's important that they should be compliant and that we optimize their dose so that we monitor levels and make sure we titrate them up if necessary. And there are occasionally patients who do really well and they'll have adopted lifestyle changes too. And sometimes we can discontinue therapy, but this is really in the minority. There are adverse effects, but they're really quite minimal. The increased hematocrit is the main one. And we can do things about that. I can change dose, or you can venosect patients. As I mentioned, the fertility issue is important. So you do need to counsel men that they may become infertile when they're being treated. Sometimes they have changes to their skin with acne and breast tenderness, or and they can have gynecomastia. And in that instance, I will check estradiol levels. And again, often reducing dose helps with this. And of course, there's formulation specific side effects that we've mentioned, such as pain in the injection site or local rashes. So who should be initiating and monitoring? Well, International Society for Sexual Medicine say that testosterone therapy can be initiated and monitored by the generalist in urology or family medicine for most patients, provided that clinical guidelines are followed. How do we follow up? Well, we need to obviously check bloods at baseline. Then I monitor patients at 3 to 6 months, 12 months and annually. And at monitoring, I will obviously check testosterone levels. I'll do a full bloods count and a PSA and a review of symptoms. Once they're stabilized, usually after about 12 months, then they can go on to an annual review. Now, this is an important slide because this shows all the triggers that should make us think we need to check a testosterone level in practice. And I know there's a lot of them there, but I think these are all things where we need to be considering checking testosterone levels. And we've mentioned most of them. So if we've got men who are obese, osteoporotic, men on long-term opiate medication, for example, tired all the time, I've put that one in bold, and this is important because men often come in with that vague tired all the time symptom. And I think with those guys, we often would check perhaps a blood count, wouldn't we? Because we think, oh, maybe they're anemic or maybe their thyroid's off. But we should be thinking in men, it could be due to their testosterone. Cardiovascular and metabolic syndrome go together, so we should be checking testosterone levels in our diabetic patients. Of course, men with low libido or erectile dysfunction, they should all have a testosterone level checked. Anemia is an important one as well, because especially that chronic anemia of old age, where you haven't got a cause, their iron, their B12s are all normal, they've just got this chronic low-grade anemia. Often it can be due to a testosterone deficiency. I've mentioned at the start post-orchidectomy, especially those guys who have testicular cancer, who will inevitably come back to us after the oncologists have discharged them. They're really worth looking out for in practice. And men with depression. I often get men who've been diagnosed as depressed, they're treated on multiple antidepressants, they've never got any better, and it turns out it's all because their testosterones were low. We're moving on now to some tips and tricks and some case examples. You'll be pleased to know if you're still awake. We're moving on to sort of the patient side of things now. So tip number one is to talk about sex. I cannot express enough how important this is, because the way to the man's heart is through his penis. About 80% of men would like to be asked about sex, but only 20% would volunteer it. And the thing is, it's really important to know that erectile dysfunction is a missed opportunity, because we know that the penile artery is tiny compared to the coronary artery, and that this will get blocked before the heart. So really, erectile dysfunction is heart disease until proven otherwise. Let me just give you a case example. So this is Wendy and George. And so George is coming for his 40+ medical check. And he's complaining about loss of energy, reduced vitality, he's tired, he's not getting on very well with his wife, his muscle strength has gone, he's fallen asleep, he's just sat there drinking beer while she's doing the ironing. But he doesn't mention that he hasn't got any sexual desire anymore. He doesn't mention his erectile dysfunction. And Wendy and George haven't had sex since August 2018. I don't know what happened in August 2018 to make them have sex, but something good probably. He goes to his GP for his health check. GP does the weight, the pressure, the cholesterol, and works out that, okay, his heart age of the next 50 years, his risk is 4.7% in the next 10 years. So he just leaves with lifestyle modification advice, most of which he knew. He goes home to Wendy and he delivers the earth-shattering news that he's obese and unhealthy. So did he really want statistical evidence of knowing what his longevity was going to be? I think probably his agenda was that he wanted to feel less tired at work and better in the bedroom. So this consultation didn't really just address George's agenda, it addressed the doctor's agenda. And he's not really receiving personalised health care, and he just doesn't bother going to be followed up. But if the GP had said, look, many men with these health issues have problems getting and maintaining an erection, could this be a problem for you? Then we'd have known that he did have erectile dysfunction, he could have been treated, and much better. We know that erectile dysfunction is a risk for cardiovascular disease, and it's equivocal to that of moderate smoking. And we are, it's drummed into us to ask about smoking history. And it increases your heart disease risk over the next 10 years by 25%. But if we had asked this question, he would have had a positive AMS score, he would have had a testosterone done, for example, say it came back low at 7.2. We could therefore diagnose him with metabolic syndrome, testosterone deficiency, erectile dysfunction, all of which significantly increases cardiovascular risk. And he would have returned home with a prescription perhaps for a PD-5 inhibitor and testosterone gel. And then he may attend 6 weeks later on the way home from the gym, feeling much happier. Number 2 is communication. So how should we tackle a May consultation? Difficulty is men don't come in that frequently. So when they do, it's really important that we use male appropriate language, that we're direct. Men prefer a more direct consultation mode, so a more doctor-centered consultation mode. We need to empower them with ownership, because they're better when they're in control. And we also need to address their health risky behavior. Obviously, we can't stop them jumping off roofs, but we need to do our best. And I developed this mainly because I was excited that I thought of the mnemonic, but this gives us sort of a little aide memoir to asking about all these things in the consultation, because we know they don't come very often and we've got to make the most of it. So M for mood, so to remember to ask about depressive symptoms and tiredness. Early disease, obviously ask about a chest pain, but check BMIs, waist circumferences, and consider screening, consider checking HbA1cs, lipids, PSA, and a testosterone on that. Nutrition and exercise, obviously asking about smoking and alcohol history and dietary and exercise habits, but importantly, sexual health. So asking about erectile dysfunction and prostatic symptoms, which often go along with that, and libido issues. Number 3 is screening. So lots of guidelines out there that recommend all men with type 2 diabetes ought to be screened. Lots of bodies globally tell us to do this, and I don't think it's actually being done, but we could pick up a lot of these men and make their lifestyle going forwards much healthier. So the British Society for Sexual Medicine recommends screening all men with type 2 diabetes for testosterone deficiency, as does the American Association of Clinical Endocrinologists, the American Diabetes Association, and the European Association of Urology. So all these bodies would like us to check testosterone in type 2 diabetic men. We did in my practice, I screened all my type 2 diabetic men. I had nearly 38% of them with testosterone below 12, and I now have 162 patients on testosterone therapy who are diabetic. Just want to talk to you about a couple of case studies. I'm whizzing through just because I know I've still got a bit, I'm running out of time, so excuse me if I'm going a bit quickly.
Yeah,
so this was,
hurry up a bit, doctor.
Hurry up, I know, I'm going for it. So this was a guy that I picked up in my diabetic screen. He was 54-year-old office worker, Chris, and he'd had erectile dysfunction for several years, and it was putting a strain on his marriage. He'd been managed with respect to his diabetes and secondary care, and they'd given him Viagra just when he needed it, but it didn't really work. And he just didn't think anything more could be done about it. But then he had his bloods taken in the screen. He had a total testosterone of 5.6. And he came to see me to discuss this. And on question, it transpired that his erections were dreadful and he just wasn't interested in sex anymore. His AMS score was 48, which is moderate to severe symptomatically. He had a waist circumference of 42 inches. Sorry, I've converted to inches, not centimeters now. And his HbA1c was 68. So he was counselled, and no reason not to go on testosterone, so no contraindications. So he was started on testosterone therapy. Received a daily gel, and a PD5 inhibitor was changed to a daily dose. 2 years later, so in the blue on the graphs is his initial score, and the sort of yellowy colour is 2 years later. But his testosterone had gone from 5.6 to 15.9. His symptom score had gone from 48 to 32. His waist had improved from 42 to 38 inches, so he could. And how many diabetic drugs could improve a HbA1c that much? But what was lovely was he said, thank you so, his wife came to see me and she said, thank just to remind me, this is actual footage of case number. He was also diabetic, but he also had a single test had been ripped out in a conveyor belt accident at work, but he'd never had his testosterone checked. Decreased libido was his main complaint. So again, you can see improvement for him. So his 2 years later, his level had improved to 28.1. His symptoms improved, waist again, and his HbA1c. And indeed, prevention is better than curing. If we can pick these guys up, can have a much better future morbidity and mortality. So which patients should we be screening for? Well, I've mentioned all this. We should ideally be screening all these patients for testosterone deficiency. But, you know, it's difficult. We're so busy in general practice. It's hard to do this. So maybe just pick 3. Obesity, type 2 diabetes, and erectile dysfunction would be a good start. But if you only end up doing 2 out of those 3, that's okay, because in the words of the wonderful Meatloaf, who sadly passed away, 2 out of 3 ain't bad. And that really was just so I could put my meatloaf in there. So we are on conclusions, you'd be pleased to know. We need to address health inequalities between men and women. In primary care, we are in this excellent position to help guys use the service better and promote this better health-seeking behaviour and a perception of a healthier lifestyle. We need to remove this stigma associated with and having ill health, that it's okay to be a man who's got health issues. That GPs need to take ownership of these issues, and we need to be proactive about tackling this to prevent men reaching older age with worse morbidity and mortality. And GPs with more knowledge about men's health perhaps need to help fellow GPs so that everyone can be treated early and optimally. And I think we need to work well with our secondary care providers as well, so we can optimise men's healthcare provision. Because we may only get one opportunity to positively impact the health of any given male patient, and we really, really don't want to waste that opportunity. As I know, you can't, as Mark Twain says, you can't throw a habit out of the window, you have to coax it downstairs one step at a time. I've whizzed through just about on time. Sorry, it went a bit quick towards the end, but I just needed to get all of that in. So I hope you followed it and I wasn't rushing too much for you. But many, many thanks for your attention. And I shall pass over to Dr. Chong now for the questions.
Hi. Hello there.
Hi, Dr.
Hi.
Chong, can you hear me still?
Can you? That's an excellent lecture and very thorough. I'm very happy to allow you to have the extra time. It's so good, right?
Sorry, it was a bit of a whiz through.
I knew you rushed at the end, but sorry to have caused that. And you have been very calm even at the end, like your slide say, right? And there are a couple of questions. Some of which I'm not going to bring it up because you have already answered it in the lecture when the questions popped up. But I think there are some pertinent points here that to bring up. For example, if a patient has symptoms of BPH, the PSA is normal and patient has lower urinary tract symptoms, and the testosterone is proven to be low, what will be your approach then? Thank you.
It used to be thought that if you treat with testosterone, you could make BPH worse, but this isn't the case. So it's still worth treating those patients with testosterone. You need to monitor the PSA anyway, so that will be monitored. Often patients with low testosterone will have an abnormally low PSA because their androgen receptors in the prostate will not be full of testosterone as they should be. So almost in a way, when you check their PSA at monitoring, so at the 3 or 6 month stage, that almost resets their PSA to what would be their normal level. So that's why it's important to check it. But yeah, you can treat patients with LUTs with testosterone. It's okay. It doesn't usually make their LUTs worse. And often these patients who've got LUTs have got erectile dysfunction as well. So make sure you ask them about that. And usually they're going to need a good way to treat them is with PD5 inhibitor, a daily one such as tadalafil 5 milligrams, which will treat both their LUTs and their erectile dysfunction at the same time, and testosterone if it's low.
Yes, exactly. And that's a very good explanation for the GP who have asked the questions. And I have questions here as well. Many of those type 2 diabetes patients that you have mentioned, they have concurrent metabolic syndrome. Some of them may have a certain amount of heart failure, or they may have a decreased EGFR. They can be at stage 3B. What will be the approach if they have a testosterone deficiency?
Yeah, it's okay to treat these patients with decreased EGFRs with testosterone. It shouldn't affect that. These guys will be monitored renally anyway, but it may make them better, you know, because it's fine to treat them with that. I don't have a problem. A lot of the patients, if you've got a patient with severe heart failure who's just out of hospital, you know, a couple of months after diagnosis, then hold fire, because at the minute you need to stabilize their heart failure. But further down the line, you know, if we're now looking at treating a lot of geriatric patients and that with testosterone, because they will be improved in many other ways as well. And it should be fine with respect to their EGFRs, because really you're just replacing to normal levels. So their testosterone levels will be abnormally low. And if into levels of what, 15 to 20, you're replacing them to normal physiological levels, which would be expected. So you're not going to treat them to levels of 30. So they're going to, you know, their libido is going to go through the roof and they're going to be having sex all the time, which will go, but you know, you've got to be sensible.
Hi, Golf. Can you put the panelists' video up as well? I'm not seeing myself here. Yeah, the treatment failure in patients. We are worried about a certain amount of fluid retention in these two categories of patients.
Yes,
however, sorry.
Yeah, you're right. And but in reality, I've never had an issue. It used to be the same with sleep apnea, used to be a contraindication, but that's not the case anymore, because it seems to be, it's a bit confusing, and this used to confuse me as well, but it seems to be that actually treating these guys, you kind of lose excess fat around the neck area, which can help sleep apnea as well. So yeah, it's okay.
Yeah. If the patient is on hemodialysis, already end-stage renal disease,
okay,
and requested for testosterone therapy, what will be your approach?
Okay, well, you think, well, if this guy wants to feel better, then that's okay. So I think you have to have that sort of almost philosophical debate with them and think, well, if you want to take testosterone because you will feel better on it, and whatever you've got left of your life, you may want it feeling better, then it's reasonable to go on to it. It may improve their anemia if they've got that from end-stage renal disease as well. So they're going to feel better from it. I think you have to take these patients on an individual level and discuss it with them. But, you know, I think I'd rather feel better for my life than not.
Yeah, and especially when their life expectancy is already limited. It's better to have a feel-good factor, quality of life.
Exactly.
Usually the study in quality adjusted life years could be improved, right?
Yeah,
and,
I mean, yes, exactly. There's a lot of people would rather live slightly shorter feeling great, or, you know, much better, than a long time feeling dreadful. So it's all about that.
Here, we understand that the erythrocytosis can be helpful, for example, in such patients with a little bit anemia, for example, is kidney failure, right? And between the long-acting, short-acting, and topical, which one will be the safest? Maybe it's good to share for with all the GPs.
Yes, so if you have a patient with a higher hematocrit, it's safer to use the gels for multiple reasons. One is because you can stop it easier if the hematocrit goes too high. I've even got some guys that are on every other day to manage the hematocrit, whereas obviously on the injections, it's stuck. So once it's in your system and it's raised your hematocrit, you're stuck. Yeah, the shorter, I don't know whether you have the shorter acting injections, but they're the worst for hematocrit. But the long acting injections are sort of second worst, and the gels are the best for hematocrit. There's a new study coming out soon. It's not published yet, so I've not mentioned it, but to show that yes, the hematocrit is more raised with the long-acting injections compared to the gels. So for safety point of view, if you've got any worries with hematocrit, you are better on gels. And if I have patients on long-acting injections or short-acting injections with raised hematocrits, I usually change them to a gel if I can. So yeah, because it is easier to titrate your dose with them as well. Yeah, I do send them for venous section as well if it does become problematical, and also recheck it and make sure they're well hydrated, because sometimes the hematocrit raise is artificial if they're dehydrated.
Thank you for the kind explanation. There's one question here. How long can you use testosterone therapy? Well, in your experience, how long your longest patient you have put on a testosterone therapy? Thanks.
Okay, so mostly it is lifelong, because like with other endocrine diseases, once it's gone, it's gone. And when you replace it, you will switch off the endogenous production. So you need to keep replacing it. So it is usually lifelong. So you maybe also ask, well, what about when, people, older people, say in their 70s, 80s. Now, where I work, there's a lot of patients, because it's a retirement area, in their 70s and 80s. And I do treat these guys because I don't think we should be ageist. And if you think about the improvement these guys can have with respect to their bone density, so their frailty, their cognition, this sort of thing. So these are people that we should be treating. There's another slide that I actually took out because I was worried about time. And the difference in mortality in the type 2 diabetics at older age groups who were treated with testosterone is even more pronounced than a younger age. And that is often the cohort of patients that we don't often treat, because you just think they're too old to have testosterone, but that isn't the case, because we can make their lives a lot better. When they looked at the T trials, which was a trial in older men about giving androgel, sorry, I say Testogel because that's what it's called with me, but androgel for a year, you think, well, their balance improved, their walking distance improved, their sexual function improved, so their quality of life improved as well. And yes, sex is still important into older age for many couples in varying degrees. So I think it's important that we're not ageist about this and look at it as a lifelong treatment usually.
May I say that it's never too late and never too old to treat them. Yeah,
I totally agree.
Age gracefully, and they have a less morbidity, right?
Yes, and you have a nicer older age then if you've got without symptoms and with better strength.
I think time is catching up, but before we go, for those doctors in Malaysia who would like to contact Bassin's Healthcare, you can go through the email here on the screen here, info@brego.com.my.
And if there's any questions that you've not come through, I'm more than, if you send them to that, and Bassin's can email me and I'll answer anything that's been missed off, because we've run out of time. That's no problem at all.
Sorry, there was a glitch there. I think we will answer the rest of the question via email, and those participants who would like to look into the questions, we can provide email to the company relevance in different countries. Yeah. And may I invite Dr. Janine to give a last practical tips for take-home message for the participants, if you have.
Okay. Please, please, please think about checking testosterone levels in men would be my number one thing, especially in younger men who come in with low mood and are tired, and in older men if they're type 2 diabetic, and all men with erectile dysfunction. Check a testosterone level. If we're halfway there, if we are checking levels, but if we're not checking them, we can't do anything about it. And no action limits, know about the levels that we need. And look at the BSSM website, and that's got it all on there as well if you're stuck.
Yes, please take care of all the men, especially all the men GPs out there. And
yeah, I know, because not many GPs are interested in men's health. So yeah, more GPs be interested in men's health.
Yeah. And on behalf of all the participants, allow me to thank Dr. Janine David for her excellent lecture, very informative, and all your sharing. And I would like to thank Bassin's, especially Bassin's Thailand, Golf, and Sam from the Thailand team for helping out so much. And for those participants from Cambodia, Vietnam, Singapore, right, from all other countries, especially Thailand as well, Kokun Kap, Terima Kasih, Kam Eun, Selamat for the Philippines, and also CSA for Singapore. And last but not least, I would like to thank Brego Malaysia for inviting me to moderate these sessions. Dr. Jenny, I will keep in touch with you via email. And again, thank you very much, and have a good day and good night for those in this part of the world.
Oh yes.
Bye
Good
bye.
night, everyone. Thank you. Bye.
Thank you, Dr. Janine.
Thank you.
Have a good day.
Thank you so
very
much.
Is everyone sort of logged off now, or do you want to have a quick chat
No.
after?
We still exposed to the group, so thank you. Yeah, we can talk afterwards.
Yeah, we will talk afterwards.
But just
So I'll just stay on for a minute, shall I? Yes.
Okay, I think it's okay. I just want to say thank you, in person with you. Okay, thank you very much, Dr. Janine.
Thank you,
Thank you so
Sam.
much.
See you in Bangkok.
See you soon. Both of you.
And just send me any questions that got missed is fine to do.
Yes, I'm gathering the question right now. Send you by the email.
Yeah,
Dr.
that's
Janine.
fine. Anything that you need is fine.
Okay, so enjoy your day. Yeah, I think
Thank
we
you.
go for lunch now. And
Yeah, lunchtime for me now.
For your
Bit
dinner.
of bedtime for you.
Thank you. Thank you
Hi,
very
Danny.
much.
Thank you, Dr. John.
Thanks so
Dr.
much.
Jenny, yeah.
Bye.
Bye-bye. Bye-bye, Danny.
Bye-bye.
Take care. Take care.
Thank you, everyone.
Bye,
Bye.
Richard. Bye, Paul.
Bye-bye.
โอเคครับปิดเซสชั่นได้เลย
Bye bye all.
ปิดเซสชั่นได้เลยครับ